Good afternoon, and thank you for joining Community Health Partners for our discussion on supporting provider transition to Medicaid Managed Care. This concept paper was released on May 18th of this year by the Department of Health and Human Services. My name is Amaret Rames, and I'm the Quality Improvement and Practice Relations Manager, and I'll be your presenter this afternoon. We have a lot to cover in a short amount of time, but we're going to provide an overview of each of the 5 sections which were included in the concept paper. We'll be doing a separate recording related to the topic of the advanced medical home model, so look for that coming soon. It's a very hot topic for many of our providers, and we wanted to make sure that we allot enough time for that subject alone. The first section we're going to talk about is an overview of North Carolina Medicaid Managed Care, because it's important that we look back at the framework for how we got here, so that we can better understand the big picture. Back in 2015, you may recall the release of Session Law 245, although if you're like me and you do not have the number memorized, it may just be the law which directed the transition of North Carolina Medicaid and health choice programs from a predominantly fee-for-service model over to the new managed care model. Since this bill was signed into law, the department has coordinated with the North Carolina General Assembly to plan this transition and to map out the actual execution strategy. They've released a total of 7 concept papers outlining this, the most recent, of course, we're discussing today, and the ultimate goal of this whole effort is to improve the health of all of our North Carolina Medicaid recipients through a whole person-centered, coordinated, which is the key here, system of care that addresses both medical and non-medical drivers of health. We all know that social determinants of health is a huge buzzword right now, and the medical needs of our community truly are tied to those. Community Care of North Carolina has successfully managed Carolina Access to and Health Choice beneficiaries since 2001, so this framework will look to expand on those concepts already developed that have proven to be successful. The Department of Health and Human Services is responsible for oversight of this entire project, which includes the development of policies, holding the prepaid health plans accountable, which we'll talk about in more detail shortly, as well as monitoring all aspects of care management. Now, the prepaid health plans are sort of the middleman between the department and the providers. They're the ones that are going to bear the financial risk. They will receive funding from the department and then will distribute payments to providers for services rendered to their beneficiaries. The provider can choose to provide their own case management for patients, allow the health plan to provide case management services, or contract with an external agency, such as the case for many of our providers right now who are currently working with their local CCNC networks. Let's talk about the prepaid health plans for a minute, because these are the new players to the game that we're not used to. Now, remember, the Department of Health and Human Services will delegate direct administration as well as that financial risk to the health plans who receive a monthly capitated payment. These health plans have to create and maintain an adequate network of providers that can successfully meet the needs of the population across the state. To achieve a vast network, the health plans must contract with a diverse range of providers. They have to ensure participation from enough primary care providers and specialists, as well as including all essential providers. Now, this means the health plan networks will have hospital-affiliated providers, independents, FQHCs, rural health clinics, all of these types of entities. If a provider is willing to accept reimbursement at the established rate floor, then the health plan must contract with them unless the provider does not meet objective quality standards, which are laid out in the law. So what are objective quality standards, you ask? It's not anything related to your previous PQRS, meaningful use, MIPS scores. All they're talking about here is a history of malpractice concerns, fraud, waste and abuse enforcement sanctions. So anything outside of this will not be taken into an account from objective quality standpoints. Most Medicaid and health choice populations will be mandatorily enrolled in the managed care plans, although this will be done at staggered intervals over approximately a 5-year span. Now, there are a couple of populations which the state has decided may be better served outside of the new managed care plans. There are two categories here. There's the exempt category, which means the beneficiary will have the option to remain in a fee-for-service plan or to enroll in a managed care plan. And then there's the excluded populations, which will be required to remain in the fee-for-service plans. Currently, the only exempt population is the Eastern Band of Cherokee Indians, but there are a couple of groups that fall into the excluded category, and some of those include dually eligible beneficiaries, those involved in foster care, CAP-C, PACE, or Family Planning Medicaid. In a previous concept paper, the department outlined several efforts to ease administrative burden to providers. We'll touch on those briefly, but if you would like more information, it can be found in the North Carolina's proposed program design for Medicaid Managed Care, which was released back in August of 2017. These efforts include attempts to standardize and simplify administrative processes across health plans. We all know that it's already difficult enough to keep up with what Medicaid wants versus Medicare, United versus Blue Cross. So imagine what a nightmare it would be to have to keep up with the processes across 4 Medicaid health plans. The department is going to streamline administration across the health plans to ensure this doesn't happen. This includes the provider enrollment and credentialing process. They also want to establish a single statewide drug formulary for use across all health plans. Again, we're already getting quarterly changes to the PDL, and we don't want to make that process any more cumbersome or difficult to navigate than it already is. The health plans will each be required to cover the same services that the current fee-for-service plans cover. Also, the current definition of medical necessity, which is used by the department, will continue to be the standard for coverage decisions. Lastly, the department wants to focus on providers through transparent and fair payments, as well as by providing some contracting guardrails. You're already aware that there are some administrative simplification efforts proposed for provider enrollment and credentialing. Now that you have the 30,000-foot overview of Medicaid Managed Care, let's get a little more into the weeds regarding the enrollment and credentialing process. Providers are going to enroll in the managed care plans in a process that's very similar to the current enrollment process. You'll still access the standard enrollment application online, submit your credentialing information, and then be notified of your approval in the same way. The prepaid health plans do require some additional information, which has not historically been requested for enrollment, but this is because the health plans have additional standards they have to meet to ensure they maintain their national accreditation. What's the hardest part of any big change? It's always the transition period, right? Well, the transition period to Medicaid Managed Care is no exception. That's why we felt it was so important to call out this specific process to you. Again, we're talking about a staggered rollout over approximately a 5-year span, although the bulk of the implementation will occur in the first 6 months. It will be a little bit of a process. You will continue to enroll and re-enroll in Medicaid using the current process in NC Tracks. The Department of Health and Human Services will supplement the existing enrollment data with additional information that is collected from a national provider data clearinghouse. This set of information will then be sent to each health plan. The health plans will be expected to accept the information and use this to complete their contracting process. You as a provider are not going to be expected to give credentialing information to every health plan you elect to contract with. In fact, the department intends to prevent health plans from requesting additional information from providers because we want to deter the back and forth burden. We've talked about the transitional process for provider credentialing and enrollment, which doesn't look too terribly scary because it's mainly a continuation of what you're doing. But what does the end goal look like? Well, that's going to come in the form of a provider data management solution and credentials verification organization. A lot of letters in this, I know. But this will not be operational when Medicaid Managed Care launches. It will be developed over time, just like the managed care rollout will occur over time. Once it is available, providers will be able to access a single online application to enroll or re-enroll, and then submit documentation for credentialing through the PDM CVO portal. This portal will verify the information submitted against all available primary sources, which include national databases, available state and federal sources, information collected by national health plans, as well as other licensed databases. You may have already been approached by one or even several health plans to discuss contracting opportunities. This is standard business practice for a health plan who intends to respond to a request for a proposal. The reason for this is because when the health plan submits their proposal, they'll be required to demonstrate that they meet North Carolina's Medicaid network adequacy standards. This goes back to that vast and robust network we discussed. The health plan wants to be able to say they've engaged with X number of clinicians to support the fact that they will have an adequate network to support beneficiaries. The verbiage from the concept paper I want to stress is that health plans should not pressure, coerce, or otherwise compel providers to sign contracts. They are more than welcome to tell you what they bring to the table, but always remember that they can never push you to a seat at that same table. One of the ways a health plan may attempt to engage you is through a letter of intent. This is a non-binding indication that merely states you, the provider, intend to contract with the health plan as long as the two parties are able to agree to contractual terms. If you do sign a letter of intent, you do not have any further obligation to sign a contract if the terms presented are not agreeable to you. On the other hand, you do not have to sign a letter of intent in order to contract with the health plans after the procurement process is completed. It is not a required precursor for a contract between the health plan and the provider. It's just a tool the health plans may use to influence the procurement process. Always remember that not all health plans will be awarded a contract, so you may sign a letter of intent with a health plan who ends up without a contract. If this happens, you don't need to worry. Just be aware that may be the case if you don't hear from them again. Although I can argue like an attorney, I'm not one, so I'm unable to provide legal guidance on contracting. However, I can provide you with the tips outlined in the concept paper by the department. The following are some key items to consider prior to signing a contract with any of the health plans. This list is not inclusive and is merely a recommendation of where you should start with your discussions. First and foremost, make sure that you are clear on any rates and reimbursements for services, as well as opportunities for alternative payment arrangements. The health plan may offer additional incentives for quality and utilization performance, so it never hurts to ask. Also discuss what sort of reporting you will be required to do should you participate with the plan. Ask them what data tools and other available resources they have to assist you, as well as how they intend to help you improve the quality of care offered in North Carolina. 3 processes that tend to be problem areas are prior authorization, timely filing, and dispute resolution. Make sure you understand all of the requirements outlined by the payer regarding these. They can vary from payer to payer, so never assume. Lastly, you want to inquire as to contract renewal and termination clauses. You always want to know what you're getting into and how hard it's going to be to get out of. We can check off the overview and contracting process. So now let's talk about your bread and butter. Let's discuss the provider payment and reimbursement. The provider payment requirements, or those minimum rate floors, are going to be established by the Department of Health and Human Services. Those rate floors will apply to in-network physicians, pharmacies, hospitals, and nursing facilities who choose to contract with the health plans. There will be an additional per member per month for care coordination and management to providers who meet advanced medical home standards. Just a reminder that we'll be releasing a second webinar on just the advanced medical home model in August, but we'll touch on it briefly in just a moment. Remember, there's some flexibility for alternative payment arrangements, So if you meet certain benchmarks, whether it's a quality or utilization threshold, you may be eligible for some extra incentive money, so be sure to inquire about that when you're contracting. The health plans are required to reimburse pharmacies based on the current fee-for-service rates for at least the first year of the program. If you're wondering how this applies to you, remember the pharmacies are an extension of your care, so while you do all in your power to provide the best care to your patients while they're in your office, your extenders, such as pharmacy, need to be reimbursed so they can support your plan of care. Now, state-owned and state-operated facility reimbursement rates have not been established yet, and there are still ongoing discussions regarding them. However, it's proposed that the per member per month continue to local health departments for OB case management and care coordination for children, or the CC4C program, for at least the first 2 years. There have been a lot of questions surrounding who should I sign with, who should I not, what happens if I do sign, what will happen if I don't, and while we can't directly answer those questions because we aren't a legal advising entity, we can provide you with the details of what reimbursement will look like if you're considered out-of-network with a health plan. The health plans will cover out-of-network services, which of course indicates you did not sign a contract with them, if they're unable to provide necessary covered services within their network. Let's say, for instance, you're a pediatric gastroenterologist who's considered out-of-network with one of the health plans who doesn't have that specialty in their network. If you see one of their patients, they'll pay you as though you're in network because they're not otherwise able to provide that service. Also, if the health plan made a good faith effort to contract with a provider who refused, then the health plan cannot pay more than 90% of the Medicaid fee-for-service rate, so you're already looking at a 10% cut off the top if you opt out of a health plan who wants to contract with you. This also applies if you did not meet objective quality standards, which were those malpractice concerns or fraud and waste abuse sanctions. Family planning and supplies, as well as emergency services, will be covered regardless of whether you're in network or not, but out-of-network emergency and post-stabilization services cannot be reimbursed above the Medicaid fee-for-service rate. We do not know what the minimum standard is there, we just know they've set the maximum at the fee-for-service rate. Out-of-state non-border hospitals will be paid directly at the established fee-for-service rate. Now that you have a basic understanding of in-network versus out-of-network reimbursement, let's discuss the prompt payment policy. Now, the department has established each contracted health plan has to distribute timely payment as long as the claim is submitted within 90 days of the date of service. So this first point is really speaking to provider accountability and stating that the department intends to hold you accountable to submit claims within that same 90-day submission window we're accustomed to. Beyond that, everything on the slide is specific to the health plans. The health plans are responsible for notifying you within 18 business days, so not including weekends or holidays, if the claim is clean or if they require additional information in order to process the request. Once the claim is considered clean, it must be paid or denied within 30 days. If this does not occur within the specified time frame, interest can be charged to the health plan at an annual rate of 18%, starting the day after the day the claim should have been paid. The health plan may also be subject to an additional penalty of 1% of the claim per day it's late. Providers do not have to make a separate request or file a separate claim for these penalties. It will automatically be taken into account and applied. Up until this point, you may feel as though you're the only one being held accountable for high-quality patient care. Well, now we're going to do a 30,000-foot overview of the accountability which the health plans will be held to, just so you can see it does carry all the way through the process, and you're not the only one being held to specific standards. The department will be responsible for ensuring health plans are compliant with their contracts as well as general oversight of the project. This will include review of encounter reports and facilitating file submission or resubmission. They will have to approve any materials the health plan intends to distribute to potential or existing beneficiaries, in addition to maintaining a presence in the community to ensure that distribution follows protocol. The department will have to approve all provider contracts and manuals. They'll also periodically assess the health plan for network adequacy and access to care reviews. This goes back to that robust, diverse network we talked about. So the health plans have to demonstrate this throughout their contract and not just at the beginning. In other words, they can't just sign up a robust network initially and then choose to terminate contracts with a particular group, such as all independent providers, 6 months after they're awarded their contract by the department. In addition to these reviews, the department will also conduct contract compliance audits and issue letters of concern and corrective action plans, which they'll approve upon submission from the health plan when deemed necessary. During the procurement process, all health plans will have to go through an external quality review, which will be performed by a non-biased third-party vendor. This vendor will look back for a period of 3 years to ensure the health plan is compliant with what the state deems standards. They will validate performance measures, encounter data, and performance improvement projects, and they may even choose to conduct surveys from consumers and providers regarding the quality of care that was received under the health plan. Summary reports of the ECRO's findings will then be compiled, provided to, and utilized by the department to evaluate overall performance of the health plans. The last topic on our agenda today is the advanced medical home. As I previously said, we will be doing an in-depth presentation on this subject alone, but we wanted to at least give you the basics today. There will be 4 tiers of advanced medical home levels, although only tiers 1 through 3 will be utilized during the first 2 years. In the first year of program launch, the tier structure will provide continuity and predictability to the full range of practices participating in the current Carolina Access Program. Tier 1 and Tier 2 can be compared to the existing Access Program. If you're currently a medical home participating in Carolina Access and Carolina Access 2, you can expect to be given a designation of Tier 1 or Tier 2. This will still result in the same per member per month payment for care management services, which will be the responsibility of the health plan to conduct or coordinate. Practices will be responsible for care management services in a Tier 3 designation, although these services can be performed by a clinically integrated network rather than at the specific practice site. Tier 4 will not be introduced until year 3 of the transition. This table outlines the current proposed tier structure for Medicaid Managed Care. We're not going to go over the entire thing, but I do encourage you to study this on your own when you have a quiet moment, as it's a very important concept. Over time, the tier structure is going to evolve to encourage practices to align with the department's care management goals, while still ensuring practices and enrollees are supported in this transition. If you have any questions or would like to discuss the items addressed in further detail, please feel free to contact any of our staff members listed here as part of our leadership team. Thank you for joining us today, and we look forward to seeing you during future presentations. Have a great day.